Good morning. Good morning. Good morning. Can we settle down, please? We're ready to start. Good morning. Good morning. Good morning. Good morning. Can we settle down? Ninjani, Sabonani, habari gani? Welcome, 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 welcome. My name is Anne Githuku Shongwe. I'm UNAIDS Regional Director for East and Southern Africa. And with me is my co-moderator, Sanbonani, Ninjani. My name is Dr. Tembisile Kulu. I am the Chief Executive Officer of the South African National AIDS Council, and I'll be your co-program director for the day. Thank you. Colleagues, let me begin by acknowledging all the protocols and who is present with us. Let me begin by acknowledging His Excellency Minister Motsoaledi, Mr. Aaron Motsoaledi, Minister of Health, who is here with us. Alongside him is our Executive Director, UNAIDS Executive Director, Ms. Winnie Byanyima, who is also with us in the House. We also have with us Deputy Minister Steve Mapaseka-Letsike, who is with us as well. We have the UNAIDS Global Alliance patron, Second Lady Ms. Humile Mashatile, also with us. We have with us the MEC for Health, Nomantu Nkomo Relihoko, also with us. We have the Executive Mayor of Ekurhuleni Metro, Nkosindiphile Kaza. He told us that there are over 4 million people here in Ekurhuleni. Big, deep respect, Mr. Mayor. We also have with us other UN representatives who are with us. I see our regional director for UNFPA. I also see the presence of WHO, of UNICEF, of ILO. I don't want to get into trouble, but any other UN agency that I don't see in the House, I want to acknowledge you as well as our colleagues from PEPFAR, who I see as well, and others from the Diplomatic Corps. I also want to acknowledge the CEO of the hospital, Dr. Lebogang Khumalo, who has given us a wonderful tour of the hospital. The MMC for Health, well, we already have the MMC for Health, I think is also in the House. We have SANAC Civil Society Forum Chair and SANAC Co-Chair, Mr. Soli Duku. We have Professor Helen Rees from WITS RHI, who is with us as well. Dr. Linda Nkomo Ngube, Nelson Mandela Children's Fund. Dr. Tutula Balfour, SANAC Private Sector Forum. We have Professor Mbulela Ndiase, who is the PLHIV sector representative with us. We have other members from civil society. And I want to just acknowledge everyone who is attending. I don't want to minimize anyone who's in the House, but to acknowledge all those who are here, who've taken the time to be present for this global launch. We are live and therefore want to acknowledge the world that is watching us and recognize that there are more of us here. I want to hand over briefly to my co-chair.
Thank you so much, Anne. Before we go on to sing the national anthem, I'm just going to clarify a few housekeeping rules. Our ablution facilities for our guests are outside on your right-hand side. Outside this door, on my left-hand side, are the ablution facilities for the principals. So if we may keep that place, that space open, because it's also required for security and evacuation services. Before we sing the national anthem, I'm going to ask that we kindly all rise to observe a moment of silence in honor of our former Deputy President and Chair of SANAC, Comrade David Mabuza. He passed away last week and will be buried this weekend. Thank you so much. May his dearly departed soul rest in peace. You may take your seats. Back to you, Anne. So we are all aware that Bab David Mabuza was the chairperson of SANAC. There are multiple memorial services that are happening on his behalf today. The funeral will be this weekend, and he will remain remembered as the chairperson of SANAC, who really championed the HIV and the TB response in his tenure as the deputy president. I'm going to ask that we rise once more to sing the national anthem. Thank you. Okay. Mm-mm. South Africa, Thank you, say yeah. Waar die kransen antwoord geeft, sounds the call to come together, and united we shall stand. Let us live and strive for freedom in South Africa.
Thank you. Kindly be seated. Thank you all for joining us for this high-level launch of UNAIDS, UNAIDS Global AIDS Update 2025. This is a report that we release every year with different themes, and you will hear in detail about the theme. This year's theme is AIDS Crisis and the Power to Transform. In previous years, we have had in 2024 the urgency of now, the path that ends AIDS, communities at the center in another year. Every year we pick a theme that is pertinent to the issues at that time. We have an exceptional list of speakers with us today. So in the next 60 minutes, you'll hear from the Minister of Health of South Africa. You will hear from the Executive Director of UNAIDS. You will hear from our MEC, our Mayor. You will hear from our patron, the Second Lady of the Republic of South Africa, civil society, young people, researchers. We will focus on the powerful partnerships between UNAIDS, governments, and communities to hear how together we have the power to transform and end AIDS by 2030, despite the funding crisis. Funding crisis has been faced by many countries in our region and across the world, and we are here to listen to the results of this report. Let me hand over to my co-chair for our next speaker.
Thank you so much, Anne. So you'll note that today's program is divided into three parts. The first is a welcome address by the provincial executive, the executive mayor. The second part of the program is a panel discussion. And then the third and the last part will be messages of support from civil society, from the private sector, as well as from government. And then we will conclude with a vote of thanks. I just want to acknowledge that this is the second time that South Africa has been asked to host the launch of this report. The first time it happened was in 2019, where we hosted Eshowe, and that was in the King Cetshwayo district. That was one of the first districts to reach the 90 targets prior to the end point. So halala, South Africa, halala. Thank you very much to UNAIDS for actually choosing us to be the host of this report. And on that note, Baba Umeya, Babu Kagaza, may we please ask you to come and do welcoming remarks. Thank you. Please, a round of applause for the mayor and the MEC. Thank you.
Thank you very much, Program Director. And I think according to just the protocol, we allow the MEC to actually welcome us. But welcome to the city of Ekurhuleni.
Yes.
We will do the vote of thanks. Thank you very much.
Thanks, Mayor. Thank you, Mayor, and let me greet the program directors. You can see, DM, that Mayor knows that he will be recalled if he doesn't do this today. I have all the powers. Thank you, program directors, Dr. Thembisile Kulu, who is our SANEC CEO, and Madam N. Chituku Shongwe, the director of UNAIDS Regional Support Team for Eastern and Southern Africa. Minister of Health in the Republic of South Africa, Dr. Aaron Mtswaledi, Deputy Minister, who's here with us. And thank you so much for the support, DM, that you always give us in the region and in the province. Executive Mayor of Ekurhuleni, Councillor Nkosindiphile Xhakaza, our second lady in the country, Mme Mashatile, UNAIDS Executive Director, Ms. Winnie Bainyima, Patron of South Africa Global AIDS to End AIDS in Children, Ms. Humile Mashatile, Siyabonga Sisi again. Thanks for the support. I know we have programs that you said we must do together in the province, and we are ready to do that. Our moderator, Ms. Lerato Mbele, panel participants, distinguished guests, civil society partners, that is led by the chairperson, Gladys Chabalala, who's amongst us, faith-based leaders and colleagues, officials from various spheres of government, including my CEO, Lebu. I hope we have showed them all the best places at Bethakbo. I've been telling Minister about Bethakbo, our hospital, and I hope you didn't disappoint, because Minister is going to hold me accountable for that in the NHC. Ladies and gentlemen, good afternoon. It gives me a great pleasure to be part of this historic occasion, which marks the launch of the annual UNAIDS Global AIDS Update Report. This annual event, hosted in various countries across the world, has become a very significant occasion that serves as a reminder that the fight against AIDS, HIV and AIDS is a relentless one, which now more than ever before must be sustained. Gauteng carries a big part of the HIV burden, but also the power to lead. We are proud to have achieved 94% of the people knowing their status, with 83% on treatment and 93% virally suppressed. But we know that the second 95 remains our biggest challenge, especially young people and men in particular. As a province, we are among the first to launch the 1.1 ART gap campaign, where we aim to put over 326,000 people on treatment. We're taking this campaign to universities, to townships, to informal settlements, and to hostels. We're reaching communities through a multifaceted approach that is involving weekly radio slots and corner-to-corner campaigns, amongst others. Our mission is to ensure that no one is left behind. Despite the funding cuts that forced some of our NGOs to either scale down on their work or close, We continue to work with civil society, launching including the Gauteng AIDS Council to keep the momentum strong. And we have expanded youth zones, trained over 200 new HTS counselors, and deployed mobile clinics to reach to the most vulnerable. And Minister, what we have done now is to go to the taxi ranks. We are now building clinics in the taxi ranks. The first one that we have done in partnership with Empathy, it's in Orange Farm, and we'll take you there because the men in that taxi rank, they were very appreciative of the initiative of building the clinics right to where they are, because they are saying they've been scared of going to the clinics or hospitals because of the stigma. So we will take you there so that you can see when we roll it out even to other bigger taxi ranks, as they have been asking, because we're working with the taxi associations again in the province. So as a convener of faith-based organization on behalf of the Gauteng provincial government, I've been mobilizing the sector to also play a more impactful role in fighting the stigma and encouraging hope. Thank you to UNAIDS, SANEC, and all other partners that have been working with us. Your support reminds us that this fight is about people, not just numbers. Together, we'll end AIDS as a public health threat. To UNAIDS, thank you for choosing to launch this global report in South Africa and especially in Gauteng. Our province is a critical battleground and a strong voice of universal health coverage and the full implementation of national health insurance. We are committed to do our part to ensure that we contribute towards the goal of achieving UNAIDS 95-95-95 targets and to end HIV/AIDS by 2030. Thank you. Ndiyabonga. Thank you.
Thank you, MEC. And before I lose my job, MEC, I would like the people to know who was addressing them. So this is Umama Unomantu Nkomoralehuku, who is currently the MEC for Health and Wellness in Gauteng. And she's also a newly elected member of the National Executive Committee of the ANC Women's League. I'm saying this because she is the only MEC who runs a Department of Health and Wellness. We were discussing this with the minister earlier, that health does not begin at the entrance of a facility. There are so many social determinants of health, and a lot of them have got to do with our wellness and our well-being, starting within the societies where we live and just the basic food that we consume. We are going to proceed with the second part of our agenda, and I'm going to hand over to Anne to announce our panelists. Thank you.
Thank you so much, Dr. Xulu. Let me start by inviting Ms. Lerato Mbele, who's our South African journalist. She's our moderator for this panel. So if I can invite her up, I think she's well known, has been on the BBC, worked with Africa Business, Newsday, Report and Newsday, and other many well-known journals. Lerato, I think I'll invite the speakers, or do you want to do that? I can do that. So can I please invite the speakers to come up on stage? If we can have Dr. Aaron Motsoaledi, Honorable Minister of Health of South Africa, to come up on stage, please. Ms. Winnie Byanyima, Executive Director, please come up on stage here. Can we have Ms. Joanne Betty Wani, who is Program Coordinator for Adolescent Girls and Young Women's Network in South Sudan, also to come up on stage. There are stairs on the left, on my right and on my left. Reverend Mbulelo Jasi, Executive Director of Sanarela, please come up on stage. And Professor Helen Rees, Executive Director of WITS RHI. Sis Lerato.
In the middle, next to the minister. Reverend over here. Thank you very much to the program directors, and thank you very much to the audience for great. So I hope these microphones hold up, and also thank you very much, audiences online watching via stream. Conversation. May I request that our panelists keep your submissions succinct? That way we can have more of a dynamic flip. It's to me that the microphone required to be facing in order for the sound to be retained. Perhaps that's also true for the rest of you. So my name is Lerato Mbele, and as we discuss the global aid crisis and transformation, I want to just statistics. Should somebody fix it, please? Let's see if we are sound checking, courtesy of the Minister of Health. Thank you very much. We love a multi-talented member of the executive. Thank you, sir. All right, so as we discuss today's global update and the theme AIDS crisis and the power to transform, I want to just go through a few statistics which will be elaborated on by the executive director, but just to really remind us the path we have traveled. 40%. That's the decrease in new HIV infections, and that number stays consistent. 56%, a decline in the rate of deaths that are AIDS-related since 2010. 62%, the percentage drop in mother-to-child or vertical transmissions in the last 15 years. And 75% or 3/4, the number of people living with HIV worldwide who've been able to receive antiretroviral therapy and treatment. I'm reminding you of these statistics because whilst we are confronting a confounding situation of a funding crisis in 2025, in the past 15 years, there've been huge successes and strides. Yes, the COVID pandemic added a complicating variable, and the events of 2025, the unilateral cuts in funding definitely complicate the picture. But it has been done. The hard yards do reflect in the numbers. And so in our conversation right now, we will reflect on the crisis indeed, but can we talk about our collective agency, our social capital, corporate citizenship, policy alignment, the things that will get us over the mark in 2030, where we hope to eliminate AIDS as a pandemic and align also with other achievements of the UN SDGs. And so with those words, may I hand over now to Winnie Byanyima, the Executive Director of Global AIDS, of UNAIDS, to talk us through the figures in the global update. Ma'am.
Thank you very much, Lerato. Can you hear me through this?
Yes.
Good. I must first recognize the Honorable Minister. Wait. My papers. I must first recognize the Honorable Minister, Dr. Aaron Motsoaledi, and through him thank very much the government of South Africa for accepting to launch our annual report, the Global AIDS Update. Thank you very much. I also recognize, thank you. I also recognize my friend, Deputy Minister of Women, Youth, and People with Disabilities, Ms. Steve Letike. Thank you for being here. I recognize our patron of the Global Alliance for AIDS in Children, Second Lady, Mrs. Humile Mashatile. Thank you also for the role you play. The Gauteng MEC for Health, thank you for your opening remarks. I recognize too the Executive Mayor, thank you for being here too. Chairperson of Civil Society and SANA Co-Chair, and of course our gracious host, the CEO of Beta Gotswe Hospital, Dr. Kumalo. All of you distinguished ladies and gentlemen, thank you for being here. Let me send my condolences also to the family of the former Deputy President, David Mabuza, whom we worked with all these years until he stepped down from that role. Thank you. The data in this report, this year's report, is for 2024, last year, up to December last year. But it also touches what has happened this year, because there's been a major disruption this year. But the story up to December last year showed remarkable achievements. Some of them, Loretta has told you of, how new infections were declining, AIDS-related deaths were declining. We were not completely on target, but the direction of travel, particularly for this region, but even globally, was good. The story is one of the most successful public health responses in history, saving more than 26 million lives, showing what is possible when the world comes together to fight a disease. But the report also shows that we have gaps, that on the prevention side, we had 1.3 million people who were newly infected last year in the whole world. And that, as I said, the report torches what is happening, what has happened this year, that the sudden withdrawal of the single biggest HIV donor, combined with other cuts of aid from other governments that were happening more gradually, is putting this progress at risk, particularly for the low-income, highly burdened countries, again, mostly on this continent. If the world doesn't plug this hole, we estimate that an additional 6 million people will be newly infected in the next 4 years. So we had 1.3 last year, but between now and 2029, we could have another 6 million newly infected, and we could have 4 million additional deaths, AIDS-related deaths. Last year, the number of deaths was 630,000 across the world. So we see that this is a serious disruption, but we also see that countries, governments, and civil society are not lying down and waiting to die, that there is action, that there is transformation. We also see that the impact of this disruption, that the disruption itself is not just financial. We also see that there is a backlash against rights, laws, policies that create that enabling environment for people to come forward and get life-saving services. This is happening across the world. We see for the first time, we started compiling these reports, for the first time, the number of countries that criminalize same-sex relations or gender expression have increased for the first time. So we see that punitive laws, punitive enforcement of criminal laws is increasing. So we see that people who should come forward for services are also not coming forward because of this backlash on rights. So, as I said, we have the power to transform, and we are seeing efforts by governments, by communities to move forward and plug this hole. We sampled countries. We found out of 60 countries, 25 were talking about or planning reallocations. Some have created new sources of domestic funding like levies and so on to push forward to fill their gap. We also see more cost-effective ways of delivering services as governments integrate HIV into the mainstream of health service delivery. We see more cost-effective ways to deliver. Comes with risks, but those are things to discuss about how to fight stigma and discrimination in those contexts and how to keep communities served. So Loreto, I could go on, but I know that we need to hear from more speakers. Those are some of the highlights that we need to keep the global solidarity. It's a global disease. The fact that it is festering in one part of the world and in other pockets of other parts of the world means that it's not over. We need the global solidarity to keep fighting together, and developing countries are putting their foot forward. Rich countries must also maintain support to end a global disease. Thank you.
I'm really struggling with the microphones, but we'll get it right. Thank you so much, Winnie Byanyima, Executive Director of UNAIDS, for reminding us about the importance of global solidarity, checking also, social stereotypes and how they impact on the ability to mobilize communities, and also the importance of aligning public policy. It's not just about money. Let's bring you in, Honorable Minister of Health for the Republic of South Africa. If there's one thing about you, you're very candid about the challenges faced in public health in South Africa and the demands of the public health system in the country. But what we do know, South Africa has one of the better funded public health networks on the African continent. And by and large, it was said that more than 75% of the HIV and AIDS response was funded by the South African Treasury. So even though there've been exogenous shocks in the form of cuts from USAID and PEPFAR, South Africa felt that they could fill the gap. And yesterday was that incredible announcement by yourselves and the National Treasury as to mobilizing close on to R1 billion towards additional HIV support. Could you tell us about the horizon for South Africa and the treatment and the intervention and your response? Tell us about the wonderful work you're doing, Minister.
I missed the last part. Can I tell you about what?
I think you just want me to hear you say, tell us about the wonderful work you are doing, Minister.
Everything about our work. Okay. That will need about 2 hours. Thank you. No, thank you very much. Yes, I'm sure all protocols have been done to everybody inside the house and including my fellow panelists here. I don't have to repeat that. I think you are aware that by and large, we are the country most affected in the whole world. I don't like that tag, but it's there, it's a reality, it's living with us. And for that reason, that's why in 2010, we came here to this very district of Ekurhuleni and launched the world's biggest HIV counseling, testing, and treatment campaign. It became the world's biggest. And so at the moment, we are having 5.9 million people on ARVs. We're not very proud about being #1 in the world. And for that reason, we want to be proud to be #1 in fighting the disease, to reverse what has happened. And we've made quite a number of strides. To me, the most important one is the increase in life expectancy.
May I interrupt? May I ask you to just hold up the microphone
Oh,
closer to
sorry.
your lips? There we go.
Yes, the most important one is the increase in life expectancy. I was very proud when our life expectancy increased to 66 years, when one of the foremost AIDS activists and researchers and Professor Salim Karim, equated it to the emancipation of slaves, that the effects of that increase is like what happened when slaves were emancipated. I was very proud of it. The second figure we are proud of is a massive decrease in maternal mortality. At the time we started this project, our maternal mortality was 240 per 100,000 live births. You can imagine, because women were receiving the brunt of this disease more than any other, women and children, but we're worried about a high maternal mortality because you know what it does to a nation. And I was telling people that maternal mortality is not just about death, grief, and health. It's about the development of a country, because no country develops with a higher maternal mortality. So I was very happy that it has now decreased. It went to 109,000 just before COVID and jumped again to 119 during COVID, but it's coming down again. It was just caused by COVID, caused that jump. Now, we are very happy of that. The other figure we are very, very happy and proud of is that we want South Africans to remember this. By 2004, 70,000 children were born HIV positive every year. And we reached a figure of 70,000 by 2004. When we checked at the end of March, the number of children who are born HIV positive has decreased to 634,000. I thought you'll pat yourself in the shoulder for that. You will applaud that, honestly. Moving from 70,000 to 634,000, it's not a child's play, but that's exactly what we've been able to achieve. So for this reason, yesterday in Parliament during my budget speech, I was telling members of Parliament that South Africans must not get used to the idea that we've got HIV and AIDS and TB and they are there and they are being treated. There's a budget every year and we're prepared to live like that forever. We must start thinking about elimination. We must start thinking about getting rid of this disease. And it's within our reach. Yes, it's within our reach, and that's exactly what our plan is. And my budget speech yesterday was outlining that plan towards eliminating HIV and AIDS. I was talking to Mama Winnie here. Yeah, Winnie is a very powerful name in South Africa for your information. And Mama Winnie is a very powerful title for that matter in our country. And I was talking to her that diseases like smallpox were never treated, but we're able to get rid of them. Many people don't even know what you're talking about when you say smallpox. Why can't we do so with HIV and AIDS and TB? Why can't we do so? And why can't our plan be all in that direction? Thank you very much.
And I'm grateful for the analogy of smallpox because it's not only about money, is what you're saying. It's also about advocacy, community engagement, and people just being determined. And so maybe this is a good opportunity for me to bring in Betty Wani, Juan Betty Wani, and we call you Betty, is what I've been told. And you're the program coordinator for Adolescent Girls and Young Women's Network in South Sudan. The Honorable Minister has just said, in the early days, when people were trying to figure out exactly what is this HIV and AIDS, the largest component or demographic of people who were infected were women. And so work has been done over the last decade to really target treatments and awareness for women. And yet in a country like South Sudan, this is where the greatest vulnerability lies. It's the girl child who can't negotiate their sexual health with regards to their partners, and a society that still stigmatizes HIV. So in terms of a country like Sudan, and also the ensuing issues around conflict and instability, how does that complicate the response to HIV and the work you do?
Thank you so much.
We can hear you, Betty. Let's see.
And thank you so much, Loreto. Let the protocol all remain observed. I'm Joan Betty from the Republic of South Sudan, working with adolescent girls and young women network in South Sudan as a program coordinator. I would like to first take you through South Sudan, what South Sudan is. South Sudan is a country with closely 12 million of population countrywide. Over 9 million of the population are people with humanitarian concern. Around 400,000 people are living with HIV, but only 51% of the people know their status. The ATR coverage is only at 47% with 8,100 new infections in 2023. New infections reduced by 45% since 2010, which is still way below average in Eastern and Southern Africa, where there is a 59% decline in new HIV infections over the same period. In 2023, there were twice as many new infections among women aged 15 and above compared to the men. Inequalities esteem from persistent levels of sexual and gender-based violence. A study conducted in 2027 by the Global Women Institute and the International Rescue Committee indicates that 65% of women and girls have experienced physical and sexual violence in their lifetime, and over 51% have suffered intimate partner violence. I would like to take you on the humanitarian context of South Sudan. It was just yesterday, which is 9th of July, 2025, the Republic of South Sudan celebrated its 14 years of independence. Over the past 13 years, we have been suffering with civil unrest despite the 14 years of celebration. As a result of this, high levels of humanitarian needs affect a large population, and those girls and young women particularly are vulnerable to HIV infections. In South Sudan, under the humanitarian context, there is a lot of insecurity. In a way that there is a lot of political instability, there is intercommunal conflict, and there is a lot of natural disaster, which is like the floods. This interrupts the docents from accessing services in form of education, health services, and also leads to early marriages in the context of the humanitarian context. So it makes it difficult for the docents to get services. I can give you one of the example. We as the peer educators, we had one of our docents that happened to share with us her story during the displacement and the political instability, how they separated from the parents. And she ended up staying with the uncle. So the uncle was too much into wealth. So the uncle gave the girl to someone who was rich because the uncle wanted to gain the wealth. The lady was 13 years old, and she was forced by the uncle to get married to a man that she is not aware of his status or about his well-being. So during that process, the lady got pregnant and the man was HIV positive. She was too young to give birth to a kid who was around 3 kgs, making it difficult for her to produce. So she went for a labor period of around 1 week and 3 days. The addressing girls and young women vulnerability, we look at also the incidence of the poverty, that is economic insecurity in South Sudan. We are facing a lot of economic insecurity as adolescents in South Sudan, where most of the ladies are now going through transactional sex as a way of survival for them to get something that can sustain their living. Then when you look at the culture also of South Sudan, we are facing a lot of issue when it comes to culture. In our culture of South Sudan, women's dignity are not being respected. It is a taboo for someone to speak about the use of condoms, even for you to go and get family planning without acceptance of your husband. It is a taboo. You're supposed to first get a permission before and you go and get the family planning method. So it really makes it difficult for the adolescent girls to go and get services. And there is also a lot of issue when it comes to stigma and discrimination. Most of the ladies who are having HIV, they really fear to go and get service because they have that fear within the community or maybe within the facilities where they're going to get services from. Maybe there's a story of one of our peers also who shared with us how she's HIV positive because she got it from the parents, and it was really difficult for her to study in school. Every school that she goes to, people know that she's HIV positive, and people fear to interact with her because of her status. So the parent keep on shifting her from one school to another, and she ended up even leaving school because of the stigma.
Betty, if I may interject there, just for us to just process what you've told us, because clearly issues of culture come into play. There's the intersectionality with poverty. It adds to the vulnerability, flooding, erratic weather patterns, climate change adds to the material condition as well. And then, of course, young girls being able to negotiate their futures when sex is transactional and child brides. That problem remains prevalent. I think we just need to digest that a little bit. And perhaps let me bring you in Reverend Mbulelo Jasi, Executive Director of Sanarela, the South African Network of Religious Leaders living or personally affected by HIV and AIDS. I mean, we're talking about some of the challenges that young women are facing in other parts of the world. And I'm sorry to say, the context is different in South Africa, but I think young women would also argue that they find it difficult to negotiate their sexual rights in relationships. So when we are talking about these social issues and societies that still stigmatize people who are HIV positive, or where there's difficulty in accessing treatment, what is the role of social advocacy, community groups in raising awareness, in creating inclusion and understanding? And as I ask you this, I also want to refer to something that comes out of the report. I gave you all those statistics as to the successes and more people on treatment. But the report has also found that within the patient profile of people who are not on ARVs or other treatments, it tends to be men. Why is that?
I like my language, isiXhosa. Sivele sithi molweni. Sesi-observile ki-protocol. Thank you very much, Comrade Lerato. Of course, as a sector of people with HIV, we are worried. We were frustrated as well, especially, where is PEPFAR? Where is PEPFAR? PEPFAR, raise your hand. Where is PEPFAR? We're worried, especially with the withdrawal of PEPFAR, because really this whole process could reverse the gains. You know, we've done a lot in this country. We've tried our level best even to fight stigma and discrimination, but we're worried about the services for adolescent girls and young women, and other populations that could get infected with HIV. We try to fight stigma, especially with SANAC sectors, and we're very close to Department of Health in addressing some of these challenges. There is a men's sector at SANAC, for instance, partnering with men's forums throughout South Africa to ensure that men are coming back to care. We even created a Better Men for Tomorrow campaign to ensure that men are mobilized in this country. But Minister, I'm not buying your face. Thank you with Honorable MEC. I'm still getting my ARVs. There are no problems. Yeah, there are no problems. Whether PEPFAR is there or not, I'll get my ARVs every 3 months. And this time we're refusing to die. This time. If West and Europe, they're expecting to see us dying, not this time around. They must forget, we're refusing. So we'll make sure that we regroup to continue the work. We don't have a choice. And this time we need to prioritize. We need to come up with priorities, not to address everything. We need to make sure that we zoom in and really make sure that our priorities are making sense. This time around, I must make this panel. I want to assure you that as sectors of SANAC, we are now equipped, we are even capable of doing this work with or without your money. So if PEPFAR you decide to come back, you'll find us working. We won't stop this work.
We love the conviction. Thank you for that. All right, so let's bring in Professor Helen Rees. And first, let's congratulate you for having been awarded the Dr. Lee Jong-wook Memorial Prize for your work in public health. And it's important because it means, like others, you've been at the coalface, but on the data gathering and research side. And when we talk about funding cuts, it's not just from the pharmaceutical medication therapy side. would this also impact the research and data gathering side? Because one of the reasons that Reverend Jassy can take his ARVs every 3 months is because of medical advancements. And there are other innovations as well, like pre-exposure prophylaxis, that has been championed in countries like South Africa for young people to sort of think about how to prevent themselves from contracting HIV even before they socialize. So there's a lot of that work that's being done. How will it be impacted by the funding cuts?
Well, is this microphone okay?
It sounds okay to me. I don't know about the audience. Can we hear Professor Helen Rees?
Is this one better? Yes,
There
I
we
think
go.
so. So first of all, I know we say all protocol observed to our ministers and our deputy ministers. I want to say something else about protocol, because I'm listening to our speakers here and I know people in the audience. I want to respect 30 years of activism from many people here in this audience, which has really changed the face of HIV. And I think as we're thinking about the strides we've made, and we have made huge strides, that was on the back of probably the reference point globally about what is good community activism is HIV. And that was what got access to antiretrovirals, and that is what has continued to push the agenda, and we mustn't stop now. We must continue. So just in terms of your question about the importance of funding and what the funding cuts will mean, well, I think globally, and I'm thinking particularly about the African region, the funding cuts will have a huge impact, and not just on HIV, but because so many other humanitarian aspects of support were funded by the generosity of many countries, and particularly the US government. And I think when we're thinking about the impact of those funding cuts, including HIV, we must just remember that HIV isn't just a disease. It's a disease that in itself, if untreated, exposes individuals and populations to many other diseases. So it has a row of Skittles effect. If you have people who are chronically ill from childhood to old age and you can't treat them and you can't prevent the infection, what that impacts on is development. Development impacts on stability and security. So I would just want to start by saying, let's think about that when we're thinking about the generosity of countries, that it's about a disease, but it's about development, equity, and humanitarian. In terms of research, we've had huge support for research from many structures, including from the US government. You've heard a lot about the National Institutes of Health, and we're very much hoping that those relationships will continue. The research that's been done for HIV, for TB in South Africa has had not only an impact for the country, but huge global impact as well. Solutions for treatment, solutions for prevention, solutions for community interventions. We need to continue those partnerships because they are a global benefit. And we can't have a pandemic treaty that we all agree to and then say, let's stop the research. Those two things must go together. And for prevention, we must also say what is the next step after research, and that's access. We now have really great drugs, potentially, that can stop HIV infections. And we need to be able to access those drugs at an affordable price so we can roll them out.
You know, the report refers to the world having been on the brink of a treatment revolution. I wonder if you can just speak to us very briefly about that. Is that the scientific breakthroughs that we are seeing, how close are we to finding a solution that doesn't need money, perhaps?
Well, I think in terms of treatment at the moment, we've gone from the original days where people had to have cooler boxes and multiple tablets several times a day to single doses of drugs to combination drugs. But what we're now moving on in terms of the research world is cure. Vaccines have been shown to be very hard to develop for HIV. So we are still a long way, but that research agenda must continue. And what we do have are really good prevention drugs. But as I said, we can have good research findings, we can have good products, but the next thing we have to do is roll them out to the people at higher risk who need them.
Winnie Byanyima and Minister, I want us to move the conversation along now because we are dealing with a very real funding crisis. And the report shows that 80% of the AIDS response in African countries is externally funded. I think it's 66% in the Caribbean, 60% in the Middle East. So Africa, a large proportion of how African nations are managing it, does need some kind of external funding. Now, when one country makes a unilateral decision to cut funding, PEPFAR, USAID, it feels like the center of gravity has shifted. But has it really? How else can we think about funding? Because there are many countries that have been able, as you said, to keep standing regardless.
Well, thank you for that question, Loretta. You know, it's true that this region, Africa, particularly sub-Saharan Africa, has been the most dependent on external assistance, but it is also the region that has been making the fastest progress against the disease. It's the region with the highest burden of the disease and the region with the best innovations. Now, with this cut, taking away money suddenly, first of all, it raises the question of the quality of the relationship. You don't just walk away. You plan gradual transitions. Just the fact that a donor can walk away, one member can walk away with no notice, tells you that something was wrong in the relationship. The global solidarity was not on a firm basis of solidarity. So, do you want to stay in that kind of relationship? Not really. You have to start thinking about new ways of sustaining the response. First, it's important to keep global solidarity because it's a global disease. We don't even know where this disease started, but it was global. The fact that it is not ending here as fast as it has been controlled in rich countries is because they had resources, technology, and so on. But as long as it festers in some parts of the world, it will come back to hit everybody else. So solidarity is important, and it must not be confused with charity. This is not charity. This is solving a global problem together. South Africa, this country where we are, contributes to its own response, gets a little from outside as well, like 15, 16%, but also contributes to global solutions, as Helen has just said, in research. The research is for the whole world. So every country is contributing, its hospitals, its clinics, its institutions, its health workers. And what comes in from the external adds to what governments have put down for themselves. Now, we always knew that the relationship was not good, and now it is fraying. So what do? You stop the analysis inertia, going on and analyzing what has gone. You get into the solutions. This is what I say to Africa. The solutions lie in reallocations, even in the middle of these fiscal constraints. You must save lives of your people. Secondly, you must find more cost-effective ways to do this. Some of the programs that were being funded externally, let us be honest, were very capital intensive. They were not scalable. Our poor governments could not do those gold-plated programs that PEPFAR was running. That's the truth. They were great, they had good results, but no government could afford them. So a government that now has to lay a plan of an affordable way. Thirdly, there are new prevention tools that could get us down to 0 new infections very fast. We have to get them. They must be affordable. They must be accessible for us. We need the whole region to speak up, to lead a movement like you did here in South Africa, to bring the prices of ARVs down. You led a global movement with President Mandela to bring those prices down. The companies didn't want to. We need to get these new drugs 2 injections in a year for a young girl here in Africa. She'll be free, she will not get infected. We will end we're talking about elimination. That is a route to elimination. Once you are not getting new infections, then you have a few million people to stay on treatment, to adhere, not to transmit, and you are towards the end. So we have the possibility of ending this. We need to get prices down. We need to produce the medicine here for ourselves and roll it out. We can end this disease. We can do it within our own resources, but the rest of the world must not get off the hook because this disease is global. It was not invented here in Africa. We all need to put our all hands on deck. Thank you.
I've got mine. Yeah, look, I want to regard this moment as a wake-up call. A wake-up call. Because whether we like it or not, it is the responsibility of every government to provide for its people. It's not the responsibility of other governments. I understand the issue of solidarity, but every government on this planet has got a responsibility to provide for its people. That's where it must start, which means there must be very clear political will. Because I agree with, yes, I agree with Mama Winnie here, that this type of relationship where we depend on one country, and when the country is in some negative moods, the whole world collapses. Yes, it's scary. In fact, I was asking myself, how did we arrive here, where all of us depends on one country? Yes, because when this announcement was made, I was boasting to my cabinet that, no, don't worry, we're buying our own ARVs to the tune of 90%, which is good. I said the other 10% is funded by Global Fund, which is true. And I said that is not touched by PEPFAR. And I was proudly saying that. Only to discover that 1/3 of PEPFAR funding, of global funding, is from PEPFAR. And I was, here was I. No, don't worry, Global Fund is still with us 10%. Then Global Fund said, by the way, and I was asking myself how we arrived there. Now we've received a letter from Global Fund that because PEPFAR is pulled out, part of the 10 billion rand, which we're getting over 3 years, about 1.4 billion will no longer come. What do we do, as Reverend Diaz has said? Roll out and die. No, we can't allow that. We can't allow that. That's why we've been working around the clock. And I also want to state that it's not about the country being rich. I'm quite convinced about that. Let's go back to the history of this pandemic. There was a time when in South Africa we were lost and not providing ARVs. Next door to us was Botswana. We're not richer than Botswana. They are the first to provide ARVs. And they did so long before we even started, even though we are a bigger economy. And at that time, the economy of South Africa was doing very well. We had access, funds and all that. The other country that went in the starting blocks before us is where Mama Winnie is coming from, is Uganda. They also started ARVs before us, and we are still a bigger economy than them. So we can make a start, and this is what I want to promise you and the world. When I said we are going to get rid of this disease, there is hope. There is hope of lenacapavir. There is hope. That is going to change the game. It's a game changer. And I can promise that we will move mountains and rivers to make sure that every adolescent girl who needs lenacapavir is going to get it. I'm making that promise. I made it in Parliament. Because it's a game changer. Once you do that, because it's prevention, can we imagine, we've already started putting up a plan of how many young girls, numbers and all that. We already have that and we're planning. And when you ask me where we're going to get the money from, I'll tell you this. In 2010, we asked the same question. When we said we'll test 15 million people and put them on ARVs, we were asked, where can you afford it? And my answer is, can we afford not to? I'll give the same answer today.
Betty, I just want to bring you in very briefly because we're talking high level policy, research, but at a personal level, what have the funding cuts meant for the work that you do? Yeah, go ahead.
Thank you. Thank you, Loretta. The reason as to why I can look at the funding has really, it has really brought a challenge to us as the adolescent girls who are working with their peers. The reason when you look at the context of South Sudan, and I look back at the challenges that we are facing basically in South Sudan, and that was the reason as to why we had to form the network of adolescent girls. We formed this network 4 years back. It was in 2021, that is when we formed the Adolescent Girls Network to work closely with adolescents within the areas and the states, because South Sudan is wide, and to empower the girls, to protect them from HIV, to protect them from gender-based violence. And we work closely with the peer educators to reach the adolescents, to provide for them information through awareness. We also work through like the WhatsApp group, peer educator, community, and radio programs to reach those ones who are being affected by the war, like the Sudan war, those ones who are now in the camps. We use the radio station to work with them. Then the funding cuts really, our peer educators have become volunteers. They are no longer working. We don't have something to support them. They have the love of supporting the adolescents, those ones who are facing a lot of challenges on GBV, HIV. But we don't have something to support them. And for you to go to other states in South Sudan, we use the plane and it is like 2 hours flight for you to reach that side. So now we are operating just within the central, within South Sudan there. The impact of this termination of the funding has been like over 98% of the adolescents have lost their jobs. As funding is pulled back, key services like outreach, HIV testing, and safe space disappear overnight, just like that. And most of the offices were closed because we as adolescents, we are renting. We are renting offices and we don't have something that can help us maybe to pay as we are renting and as we are doing our work. And also there is a lot of increased cases when it comes to GBV and HIV. It is rising, because of the termination of the funding.
Right. Okay.
Thank you.
All right. So, yes, ma'am.
Thank you. I'd like to add on what Betty has just said. Thank you so much for spelling out so well how your really life-saving work for girls and young women has been heard. Our report shows that the impact of this sudden cut hit prevention even more than treatment, because a lot of prevention programs, prevention like she was doing for adolescent girls and young women, prevention for LGBTQ people, this work was heavily funded externally. PEPFAR alone was doing testing amongst these most vulnerable people. 84 million people, one program, 84 million people global. So the message we have to governments is step up on prevention. Don't drop it. Don't focus just on treatment. Support social contracting of communities, of youth groups, of community groups to continue serving their people with prevention programs. They're very critical.
Right. I'd like to wind the conversation down, and I'm going to refer again to some detail that comes out of the report, but I'd like us to think about how to circumvent this crisis. And I'm going to start with you, Professor Helen Rees. The report shows that 25 of the 60 low-income countries featured, 25 of those have introduced different spending models. So I think this goes to the issue of, do you spend on treatment or do you spend on advocacy? If you are doing advocacy, which targeted groups. So it's really about thinking outside the box. For the work that you do, what does that future look like if we don't just focus on the money problem, but we focus on solutions?
I think we've got an incredible opportunity. Let me try now. We have an opportunity here because with every crisis comes an opportunity. And as Mawini said, we now have a chance to step back and say, what do we do? And we have to accept that worldwide money is tight. It's not just poor countries, it's all countries. So what do we do? What have we learned? So I think the first thing we have to say is, what is the best return on investment? What are the programs that are going to give us the best return on investment? Certainly continuing treatment, keeping people in care, and then preventing new infections. That's clear. But I think that the other thing, and we've been talking about this with the minister, is to think differently about how we're delivering services. Many of these countries, we're talking HIV, but it's about health services. So we need to rethink about the intensity with which we deliver services and the inefficiencies. Can we leapfrog other technologies, AI technologies, so that we actually start to have efficiencies which also generate data, which in turn allow us to deliver better services?
Fantastic. Reverend Yasi, the same question to you. You work with the community, you work with men, you work with those receiving treatment. Regardless of the money problem, what can be done better as we really steam ahead to 2030?
Let's continue to work together. South Africa is a country of structures. And those structures are well coordinated at SANAC. But we must also mobilize those who are not members of SANAC to come on board. I mean, we must protect our clinics, for instance, especially the supply chain. We must make sure that our clinics are safe, people are safe inside clinics, people are not afraid to go to clinics. Fortunately, I'm sure you are aware that there were pastors in this country who used to claim to cure AIDS. But because now we're working with the Department of Health in Gauteng, I want to make an example. MEC Nomantu, she's in partnership with faith-based organizations, for instance, including chaplaincy, to ensure that pastors are trained. Because we discovered that the reason why there was the chaos, people claiming to cure people on TV, is because people were lacking training. Now pastors are trained, pastors now are chaplains in hospitals who are no longer disclosing people in those wards to say, fire the spirit of HIV. We are no longer doing those things. We're very smart. We work with doctors. We provide spiritual care. So let's work together. Let's make sure that we support each other. We used to share resources in this country. I mean, if there is a resource from Ubabu Solinduku, let's partner with him. There's no reason, we're not going to close down our offices because of funding. We'll continue to operate. Thanks.
Betty, I'm going to ask you to share your views on just transformation going forward. What can be done better?
Thank you, Loreto, for this question. As far as the adolescent girls in South Sudan, we are mostly being supported by the donors. Our government is not supporting us at all when it comes to issues of HIV, gender-based violence, something like that. So what we really need the funding back. It should come back to support us. We need continual global solidarity to ensure we are not left behind and the gains in the HIV response are not reserved. We want access to all the new HIV prevention technologies which can accelerate to end the AIDS by 2030. We would like to also integrate the HIV and the gender-based violence services in the humanitarian context. We need to build resilient communities-based systems that can withstand the disruption of the conflict and other emergencies. I also need new policies that address the inequalities and the harmful social and the cultural norms in South Sudan. We also need to center the adolescent girls and the young women in all our efforts and make sure that there are strong systems to protect their safety and rights in their ability to access prevention and treatment services without fear. Thank you.
Thank you. Minister Motsoaledi, as Betty's reminding us, we're on the road to 2030, where it was hoped that by 2030, 5 years from now, we can eliminate AIDS as a pandemic. So what can South Africa commit itself to?
Well, we said we are going to eliminate it as a public health threat. By that time, it doesn't mean it will be gone completely, but it will no longer be a public health threat, which it is now. And we are not just dreaming. As I'm saying, there are pointers to that. Number one, UNAIDS gave us a guidance and an instrument called 95-95-95, where 95% of people must know their status. We're already at 96. Where 95% of those who are HIV positive must be on ARVs. We are still at 79. And where 95% of people who are on ARVs must be virally suppressed, such that they are no longer transmitting the virus. We're already at 94. Now, on the 25th of February, we launched a program called Closing the Gap to look for 1.1 million people who are known to be HIV positive, but are not on ARVs. And there are people who are skeptical about it. We have broken that number of 1.1. It's not a thumbsuck number. These are people who are known, who have got records of, who have got names of, some of them with addresses, even though they are changing. We know them province by province. Each province has got the number of what you are looking for. We know them by district, and we know them by facility. Like this morning, it was reported to us of the number of people which this hospital alone is looking for. And so we have already started that. Once we find them, we'll be on 95, 95, 95. That's the first thing. The second thing, don't undermine the announcement made by Global Fund in Geneva yesterday about this issue of lenacapavir. I'm repeating, it's a game changer. Only if we make sure that it reaches especially young adolescent girls. And that's what we're going to be doing. And I've already said here to some people that while we know that there are key populations, etc., 90% of what we want to spend on lenacapavir is these young girls, because they are the ones who are at risk more than any other person. And so once we reach 95, 95, 95, and you provide lenacapavir, and we are not saying we must forget about other things like condoms, etc. I'm not saying that. I'm just talking about the new entry with lenacapavir. Then we'll be on the way there. It just needs our political will and our determination and our working together.
Madam Winnie-Byanyima, you're going to have the last word. This was your global update as UNAIDS together, obviously in partnership with SANEC. So you've spoken a lot about global solidarity, looking beyond non-traditional funding methods, working within communities. But what is the real thought you want to crystallize in our minds?
The main message from our report is that there is a funding crisis in the HIV response, and we must find ways to plug that. What I've said, or what our report says to the developing countries, to countries like here in Africa, is that reprioritize, find ways to put some more into HIV because there's a big hole, but also find ways to increase your cost effectiveness, how you do this, when you're integrating, how you do this. And that brings me to the Reverend's point. By the way, I like your jacket. The point that communities are an important way to deliver service, meaning girls, young people delivering to themselves, LGBTQ people to themselves, sex workers to themselves. This is the success of the HIV movement, that services were taken from the facility into the community. So to governments, we are saying, as you find ways one of the most cost-effective ways of reaching people is to work through the communities. So that's key. And because this is a global launch, I have this message to the rich countries, is that, look, aid is just one resource flow. It is declining, we see that. And it was always with many challenges of paternalism, of the kind of problems even the minister mentioned. But there are other resource flows that countries like Africa, low-income countries, are denied because of the actions of the richer countries. They must address them. Let me give you an example. In 2023, Africa received $72 billion as aid, 72 for agriculture, climate, whatever, and health, 72 billion. But Africa lost $88 billion in illegal financial flows, most of it tax dodging by companies taking money back to Europe and America. So 88 went out, 72 came in. Even more, Africa paid $101 billion towards debt repayments, principal and interest. That debt, the interest is so high because of external factors, not because of Africa. So we are saying to the rich countries, do the right thing, agree on a way to restructure debt quickly to free resources for our countries to put in health systems. Yes, we are saying negotiate and finish the tax convention, Global Corporate Tax Convention at the UN, to close these loopholes of tax dodging, where the revenues we should collect from those who make money here are being lost. We need that convention quickly. So to the rich countries, it is maintain the aid, but the real resources are to unlock money that's caught up in paying debt and in resolving the issue of tax dodging. Thank you.
Quite poignant and powerful. I want to thank our panel for lending us your time and your insights. A summation from where I sit, Professor Helen Rees, the Executive Director of the Wits Institute on Reproductive Health and HIV. You've reminded us data, research, it matters in setting policy and in coming up with innovations on the treatment side. And those innovations can be a breakthrough, as we heard yesterday, and we should pursue those goals. Betty Wani, coordinator of the Adolescents, Girls and Young Women Network in South Sudan. You've reminded us that statistics are not numbers. They are volunteers working in advocacy. They are young women who can't negotiate their sexual rights. There are communities ravaged by war, and that collective of problems compounds the treatment and the HIV response. Minister Motsoaledi, the Honorable Minister of Health in South Africa, you've said unequivocally, the principal responsibility is for governments to provide for their citizens. External support is helpful, it's an auxiliary, but first the government owes it to the people to come up with the response, and you're committing to the people of South Africa, and then after that to the world as part of the global solidarity. Reverend Mbulelo Diasi, Executive Director of the SA Network on Religious Leaders living with or personally affected by HIV. You've said that people living with HIV in South Africa know that there are funding problems, but they are determined to live regardless of those problems. You will mobilize in those communities. Yes, there's faith, but you're going to believe in the science. Less fire of false prophets and more science and interventions by the state. And Winnie Byanyima, Executive Director of UNAIDS, the global financial architecture is skewed unfavorably for least developed countries, but there are non-traditional methods. We've started to see it in 25 nations. We're starting to see it regardless of those PEPFAR cuts. It's not always a money solution, but it's a political will solution and a global solidarity solution. We thank you for taking the time to be here. We welcome you to South Africa, and let's get this done by 2030.
Thank you, ladies and gentlemen. I've been asked to request that you all stand for a group picture carrying the report as well. Thank you.
Job.